For those of you who got to come here last year, I've decided to do a different lecture this year, which I consider the advanced course in diagnosis and medical management of stroke. But I went ahead and included the slides from the other one at the end of this. So if you've got these slides, or if you've got YouTube, last year's lectures on YouTube, you'll see it. But what I'm going to talk about today is TPA, thrombectomy, craniectomy, diagnosis of occult AFib, some anticoagulation, and then if we have time, I know the lectures after me are carotid stenosis, so I may or may not get to those. This is just a reminder of our levels of evidence, which I'll be referencing a little bit, and I'm going to use a case-based approach. All right, so this is a 72-year-old man. He has all the risk factors, but he's not had a prior stroke, and he's doing well and goes to the bathroom at 3 a.m. At 6 a.m., his wife hears a thud, and he's unable to move his right side and couldn't speak. She calls 911, and he comes to the ER. So here's his vital signs, but the relevant information is that he has a dense left gaze and a right facial droop. He has right hemiplegia, no response to sensory stimulation on the right. He has what we use as an NIH stroke scale, and if you haven't had a chance to do an NIH stroke scale, it takes about 5 minutes online to become certified. Everyone in this room is a 0, that's what you want. A patient who's in a coma is about a 30, and he's a 22. He arrives and that exam is completed at 6:30 in the morning. So wife heard him at 3 a.m. It's now 6:30, and this is his CT. And I think that there is a basic expectation of what every physician should be able to do, and I think that one of those expectations is to read a negative head CT. And when we say a negative head CT in the ER, what we really mean is that there's no bleed. And if you see a bleed, it's a bright white area. The white area in the midline on this slide is actually in the lower right-hand side is the falx. So that's just calcified meninges. That's not blood. So that's a negative CT. And then if you really want to get the A in your neurovascular course, you might recognize that there's a vessel here that's dense. So a dense left MCA sign. So the patient presented with a left gaze, right hemiplegia, unable to speak. So this is a pretty classic presentation of a left MCA stroke. Now the patient was heard to fall at 3 a.m. or was known to get up and well at 3 a.m., heard to fall around 6 a.m. It's now 6:45. Is this a patient a candidate for thrombolysis? Let's take a vote. Who thinks the patient is a candidate? Raise your hand. Who votes the patient is not a candidate? Wow, nobody likes to vote. It's about election season, people. So this patient is a candidate. So our TPA used to be a 3-hour window. And so the point here is that we've extended TPA to a 4.5-hour window, and that's a high yield point. This is a revision of our guidelines, and it comes from the ECAS-3 trial. It's worth noting that there are some caveats to how the study was done. In the ECAS-3 trial, they excluded patients over 80, those with very severe strokes, those who had, interestingly, diabetes and a prior stroke, and they excluded folks who had anticoagulation use even if their INR was normal. However, the rest of the contraindications were about the same, and in typical day-to-day management, I would actually recommend you leave the caveats out. In other words, the same way that we treat a patient, whether or not they've had those ECAS-3 exclusions, we would treat them up to 4.5 hours. So the patient gets TPA, and it's 6:55 a.m. now. They're about 4.5 hours, almost 5 hours from when their stroke occurred. What's next?
How much TPA did they get over what period of time?
Well, it's 0.9 milligram per kilogram over an hour. That's a good question, though, about over how much time, because it comes a little bit into what you're doing here. Now, the max dose for TPA is 90 milligrams. So if your patient is 100 kilos or above, they just get 90 milligrams. There's a cutoff there. So the patient gets TPA, and this is what we're dealing with. What's the likelihood that that clot, which is about 2 centimeters, is going to be lysed with an infusion of TPA? It's about 10%, which means you have a 90% chance of failure with TPA in this case. And this patient has a life-threatening stroke. So what can we do? Catheter thrombectomy, I think, is what you're saying. So there's a large vessel occlusion, and this predicts a poor outcome with TPA. So There's different imaging modalities to assess the occlusion, and right now CT angio has taken the lead as being our diagnostic modality of choice. This is a CTA in the upper left-hand side showing the left MCA cutoff. If you're using MR perfusions or MR angios, that's shown in the upper right-hand corner. And directly going to catheter angiography, I think, is actually very reasonable, and that shows this patient also having a cutoff of the left MCA. So the evidence for large vessel occlusion, this is where I get to tell you as a non-surgical specialist that we've had some real success in our field, and that we had 4 landmark studies in 2015 that really changed the outcome of these patients. When you look at a study and you want a number needed to treat, and you consider yourself patting yourself on the back of a number needed to treat, about 1 out of 40 patients is the threshold that you might say is good enough to use that therapy in practice. The number needed to treat for these studies was 2. So for every other patient you treat, you're going to basically save them from severe disability. So these are those trials. I don't expect you to see all the information, but basically the p-values across the board were very significant. In fact, 2 of the studies were halted early and still had p-values that were significant simply because they had to get to publication quickly. And this is what the American Heart Association guidelines are. We use a basic disability score. What a pre-stroke MRS means is that the patient isn't coming from a nursing home, that they're functional in some way. They're up and about doing their activities on their own, and that they did receive TPA according to the guidelines. They don't have to for thrombectomy, and that the patient has an NIH stroke score that's potentially disabling. And the aspect score is a way that we say that the CT is negative. So that's a scoring mechanism to say a negative CT. So now that we have a great treatment modality, we need to do things to get it to the right patients. So what I'm asking of you all is that if you're on the seeing your patients, if you're seeing an acute stroke and they're past that 4-hour time frame or they're looking terribly sick, do not delay. We need to get the patients to angio ASAP. So let's take a different scenario. This is a patient who already has a very large stroke. We would exclude that patient. Once the infarct has occurred, I would expect that to be obviously recognizable as a large stroke, that there's nothing we can do by revascularizing. So this is a case like that, a 58-year-old man who's found with this time left hemiplegia and right gaze.
How long does it, back up your slide, how long does it take for CT to look like that?
It depends on the patient. There's no good answer, but I would say at least 6 hours. You're not going to see that within 6 hours.
And again, remind me again, if you have this, you got this CT and you have the dense middle cerebral, you think it's occluded, why give systemic TPA? Are you saying you should give the systemic TPA and then go to catheter directed, or just go to catheter directed? You
should give the TPA and then go to catheter directed. So if you are outside the TPA window, say you've got that patient past 4 hours but under 6, don't give them TPA, go straight to catheter. The main reason is that's the way the studies were conducted. As we go forward, there are going to be studies that probably look at no TPA and straight to thrombectomy, and I may have a different answer next year.
But
so,
if you're beyond 6, you don't go to catheter.
As of now, I would say that a patient who, we're beginning, in our center, we're a little bit lenient with that criteria, especially if they have that healthy-looking brain, good-looking CT. But for the purpose of tests and things, it's 6 hours. This is a patient with left hemiplegia, right gaze, so seeming to be more like a right MCA syndrome. Again, a very severe NIH stroke scale, and this is that CT. So there is a large vessel occlusion and there is a large stroke. He's not a candidate for TPA. He's not a candidate for thrombectomy. So what can we offer? Prayer. Actually, more than prayer. The infarct's already occurred. We can offer hemicraniectomy. And hemicraniectomy may sound like something you wouldn't want to have yourself or do yourself, but this is the data, and it comes from this was actually the first study ever in stroke neurology that showed a mortality benefit. And these are the mortality numbers. It definitely increased survival. But interestingly, what it did is it increased the likelihood to almost 50% that the patients would walk afterwards. We call that a modified Rankin score of 3. So it doubles the patient's chances not only of surviving, but doubles their chances of walking. So I showed you a case of a non-dominant right MCA stroke. So again, we're thinking non-dominant hemisphere. Sure, we're going to offer that patient hemicraniectomy, but it turns out that in the outcomes of the studies, there was no difference in patients who had dominant versus non-dominant hemisphere strokes. The one thing that we do agree on is that this is really better for younger patients. Number one, they're going to swell more and be in more of a life-threatening circumstance, and they have more room to recover. And really, you want to get to those patients early. So if you see that terrible stroke, if there's a problem with that, whatever happened, don't delay in getting neurology and neurosurgery involved. There's still brain to be salvaged.
So timing on that?
Clinical, just before the patient's in a coma, ideally, and before there's any brainstem changes.
Has anybody in this room seen a hemicraniectomy?
We did 2 this week. So.
That's pretty damn uncommon, I'll just tell you. I don't know. How many done in the United States? Any idea what the...
Oh, gosh. I mean, we do. I mean, at our hospital, we probably do 1 a week.
Okay.
The trauma centers do much more than that. This basically, the whole study came from the trauma literature. So this is a little bit milder case. This is a 75-year-old woman who comes with a left homonymous hemianopsia. She's evaluated. She goes through our stroke workup. She gets her MRI. She gets her MRA. She gets her telemetry or EKG. Everything looks sinus rhythm. She does say she has some shortness of breath even without exertion, and she's sent home on aspirin. Anything else, this is what her workup looks like, anything else that you'd want to do for her? I would at least consider prolonged heart monitoring. This is becoming of interest to us to look for implantable loop recorders, to look for AFib. The number that I remember is it detects, in cryptogenic stroke patients, ones where we don't find a cause, it detects AFib in patients over 60 about 10% per year, about 10% per year. So the more you look, the more you'll find it. And interestingly, you'll see that the curve is somewhat linear. So it's not necessarily that this is the AFib that caused their stroke, but it may be that some of these strokes are in fact a marker for AFib down the road early on after stroke. And what if you find AFib? What are you going to do about it? These are the 4 new drugs, and I think there's even a 5th now. They initially were kind of lumped in the guidelines. Now they're kind of split. I think they may eventually be lumped again. But keep in mind, they're only indicated for non-valvular atrial fibrillation, and they're not indicated for artificial valves. The important thing to understand, and the thing I've learned about anticoagulation over the last 5 years, is that the disease state drives your choice of anticoagulant. If you have a patient, just because Coumadin worked in that disease state doesn't necessarily mean the novel drugs are good for that patient. You really have to see what your literature looks like. And you can know that these studies, many of these studies had 15,000 or more patients in them. So if you have a specific question about a disease state, you can ask your medical liaisons to get you information on that patient population. And what about that patient for TPA? What if they're taking a rivaroxaban or a apixaban and they come in and they're having a stroke-like symptom? So currently the guidelines say it's not recommended unless they have normal counts, including a factor 10A assay for the factor 10 drugs or an eccrine clotting time for the direct thrombin inhibitors. In general, we're basing it on what the patient says their last dose time is. Other considerations with the novel drugs, there is anti-10A monitoring available. It's drug specific, so you have to get your 10A level for rivaroxaban or apixaban, not just a 10A level. The reversal agent for these drugs is out there, but it's been postponed in its approval by the FDA, and it is presently available for dabigatran, and they all have various degrees of renal metabolism. Just enough time to maybe squeeze in one more case. This is an acute aphasia with right arm weakness. This patient has a symptomatic left MCA 90% stenosis. So this is an intracranial left MCA stenosis. What should we do about that? I hear a vote for stent. Who votes for stenting? Not stenting. The Sampras trial was done looking at the specific question of intracranial stenosis and whether we should stent. And we looked at symptomatic 70 to 99% stenosis, and medical management stroke rate in the first 30 days in 1 year was 6% and 12% versus stent was 14% and 20%. So the medical management was the standard things you'd include: statins, blood pressure lowering, and aspirin and clopidogrel. There was no favorable subgroup analysis. What I mean by that is just because the patient failed those medicines up front doesn't mean you should stent them. It's still medical management. So I don't have enough time to go into my views on carotid stenting and endarterectomy, so I'll pass it over to Carlos and the surgeon.
All right. Dr. Shaw.
Is there a path